Okay, so this is going to be a bit of a weird talk. There's two parts to it, and we literally just finished putting the slides together right now, so hopefully it all makes sense. Because part of it's on ATLS, but there was only enough stuff for about 15 minutes, so Deku asked me to kind of reinforce some of the massive transfusion stuff that's within that. So I split that apart to keep it organized and put it at the back, and hopefully it'll be practical and useful. So for ATLS, I'm going to just start off with a bit of a brief description about the course itself, and then we'll highlight a couple of the changes for the 9th edition. And hopefully, hey Chris, can you hit the thing again? Hopefully it'll click forward. And so this is how it all started with this plane crash back in February 17th, 1976, at about 6 p.m. or so in rural Nebraska. And this is what started it. On board that airplane was James Styner, an orthopedic surgeon. He's also a pilot, and he crashed in that field in Nebraska with his wife and his 4 kids. And it really sometimes takes tragedy like this to get something changed, unfortunately. And it's a really interesting story, very sad, very powerful. This is one of the quotes that came from him afterwards. He went looking for his wife 3 different times, found her on the 3rd try, checked her, confirmed that she was gone, went back to check her 3 more times to make sure that she was gone. It was a terrible, terrible situation. They flagged down a car at 2 o'clock in the morning, said goodbye to his wife, and he took his kids and drove them to a local hospital just a couple miles south of where that plane went down. And this is where it really became striking. The hospital was locked, and when he tried to get into the hospital, the nurse said, "No, you can't come in until the doctors are here." And when the doctors finally arrived, things got worse. The care that was given to his kids and to himself was really well below what we would consider standard. And he describes how, for example, the physicians picked his son up, and he's saying, try to picture the motion of his son's head and the neck as they picked him up in this improper way. And it wasn't until they got to the referral center at Lincoln General Hospital by 8 a.m., 14 hours after the crash, that he could finally become a patient. And clearly, this left a huge impact, because this is what he said at the end of it all. When I can provide better care in the field than what his children received at that primary care facility, there's something wrong with the system, and the system has to be changed. Now, that was in 1977. He got together with some friends, and by 1978, the first ATLS course was born. And the whole goal for this course was to provide one safe way of providing that initial assessment and care. It was very quickly adopted by the American College of Surgeons. It expanded to Canada the following year, outside of North America by 1986, and now it's taught in over 63 different countries. More than 1.5 million physicians have taken this course, and if they've all impacted the lives of a couple patients, the number of patients that have been impacted is countless. Now, Steiner's still active. He's an instructor. In 2007, he was actually at USC taking his re-update instructor's course, and this is a picture of him. And it's kind of a great picture because it's Styner along with Karen, who's a friend of ours, who is the person that was responsible as the chair of the committee that just updated the 9th edition. So it's Styner and Karen as the updater. And what her role was to do this update, which happens every 4 years. And in order to take it all into perspective, I think it's important to remember that, ATLS was really designed to teach one safe method of treating the injured patient, and to use really established treatments rather than those cutting-edge concepts that are just very much at the cutting edge. Things that are really easily performed, easily remembered, things that are easy to do, and especially things that can be adapted to situations that are not maybe like the hospitals that you work in right now. So it really is a simple, easy to remember, easy to do, not cutting edge, but safe way to treat patients. Now, we're currently on the 9th edition. This was released at the college meeting in the fall in 2012. And again, these updates happen about every 4 years or so. And this is the responsibility of the ATLS subcommittee of the Committee on Trauma, which comes under the guidance of the American College of Surgeons. And because this is a group of emergency medicine physicians, I'd be remiss if I didn't mention that there are numerous educational and non-surgeon medical advisors, such as ASEP, for example, who has a heavy say in what goes into ATLS. Now, for the first 25 years, though, all of the updates were really based on opinion. So the committee, as well as the advisors, would sit around and they would kind of decide what went into ATLS. But in 2006, with the publication of the 8th edition, they really made a huge move to have individual input from providers in the community, international input from providers outside of North America, and to actually focus on evidence rather than just opinion. And so with the 8th edition, there was a really big change in the content. With the 9th edition, they focused on a little bit of content changes, but there's not as much because there was so much of a change with the 8th edition, but to also concentrate on the format and delivery of the course. Now, if you actually look at the content changes, these are the 4 main things that they highlight in that paper, and that paper was published a month or 2 ago, looking specifically at all the changes in the new ATLS, and that's available at the Journal of Trauma. The first thing is team training. Now, as you know, for all of you who've done ATLS before, this was really designed and it's portrayed as a course designed to teach a provider, a single provider, how to take care of the injured patient and to do it sequentially. And this really is the case in many places where people work. But the reality is, in many other places, this is the sort of care that's provided. Now, this is obviously extreme. There's a lot of people around the patient. But trauma can be, and if it can be, should ideally be, a team sport. And ideally, that provider that's being taught is being taught how to lead and organize a team. Now, the literature is not strong. This is a compilation, one of the references cited in the new ATLS, and it really shows that although the evidence isn't great, and no matter how big the team is that you've assembled, if you use a team, you can see improvements in the time to injury diagnosis, the time to definitive care of those injuries, a decrease in the missed injury rate, and when you combine it with some sort of PI/QI process program, you can see an improvement, modest, but truly there, in mortality. And so in the initial assessment section, the next time that you take it or update it, you'll see that there really is a highlighting of the team approach to care, the preparation of your team before the patient arrives, the team dynamics as you treat that patient, and the debrief process. Now for the Airway, 2 minor little things. They've added video laryngoscopy as well as other Airway adjuncts, and you'll see that both in the text as well as in the skill sessions. And for kids, they've recommended, based on a couple of studies that I'm sure you're aware of, that cuffed endotracheal tubes are to be used, and that non-cuffed tubes are not necessary. This is one of the major references that they cite. Now, this is a general anesthetic study, but they took patients from birth to 5 years. On average, they were about 1.9 years or so. At 24 pediatric anesthesia centers, there's 2,246 kids that were randomized to cuffed versus not tubes. The average time intubated was short. It was 1.5 hours. But the 2 outcome measures that they looked at, number 1, post-extubation stridor, no difference. And the tube exchange rate in order to get that right tube in place dropped from 31% down to 2% with cuffed tubes. So based on that, they recommend that for kids above the age of 1, you can go ahead and use cuffed tubes. Now, balanced resuscitation is something that's been hit in 3 talks already this morning and probably is the biggest change in ATLS. And this is the part that Deku wanted me to emphasize and to expand on, so I put that at the very end just to keep it all organized, so we will hit that. And then there's just a little bit on heat injury that's been added, so heat stroke and heat exhaustion. And this can be at the discretion of the course director included if you want, and especially in areas where this is a problem, this can be included in the course. Now, for the skill stations themselves, I think many people will be happy to know that they've dropped DPL and pericardiocentesis. These are optional skills to be taught. And finally, FAST has been integrated into the program, and either DPL or FAST must be taught as part of your abdominal assessment. And you know, it's just impossible within the construct of the ATLS course to fully teach somebody how to do FAST, because you can use the whole time to do just that. So the purpose is simply to introduce the concept, to review images, and to give people an overview of how FAST fits into the treatment algorithm. Now, the initial assessment scenario is an important part of the testing process, has been revamped. There's several new initial assessment scenarios, and they emphasize things like geriatric trauma, rib fracture management, pelvic fracture management, some points that are really important to come out in the testing. I think everybody has struggled with multiple choice questions. So everyone, I'm sure, will be happy to know that there's 120 brand new multiple choice questions, 3 sets of 40. But we've given the course twice already, and already immediately after the test, there are numerous questions. So already, this was released in the fall of 2012, but there's 57 questions that they are redoing. And hopefully by May or so, we'll have a new updated set of questions with everybody's feedback. So apparently a lot of people have complained or sent back feedback about the questions. The instructor's course is still there. They've emphasized more practice rather than just the didactic part, and they've really taken an evidence-based approach to the whole teaching process. It still remains a 1.5 to 2 day course, but as far as the course timing, One of the things that they're looking at very closely now is a mobile learning platform for the actual ATLS course. So I think for a lot of people, it's hard if you have to travel to go to a course. It's 2 days away from your practice. It's the hotel. It's all that sort of stuff. So they're thinking and working at a program where they can split it into two, where you do part of the course at home, self-directed, in front of a computer, using the internet to go over all the lectures, followed by the stuff that really has to be done in person as an in-person session. So you can look for that to come in the future. And then finally, one of the things that's really new that they didn't have in the 8th edition is the My ATLS app. Now, in general, if you go to do a course now, you'll see that there's been a huge emphasis on increasing the multimedia content. So videos and images. Some of the x-rays are still kind of difficult to interpret, but they're really making a concerted effort to get that to be better. In accordance with that, they've built this app for the iPhone as well as for Android phones, and it's been downloaded a ton so far. In fact, in 135 different countries, many countries that don't even support ATLS at this time. This is what it looks like, and it's included with the manual that you get. There's a little icon with a little code that you can type in, so everybody gets a copy of this. And in it, there's algorithms, calculators, DIMTO maps, videos, a bunch of stuff. No Wi-Fi or internet connections required in order to bring the content up. And for any Canadians that are in the crowd, they have a switchover between metric and imperial content. And if you go through, it's actually broken into 4 different parts. There's the chapters. And in the chapters, you can see that all 13 of the chapters are summarized for you, and all the different practical checklists, the algorithms, the miscellaneous things like drug dosages, all of that stuff can be clicked on and brought up onto your phone. In the just-in-time video section, they actually provide 21 procedural videos, and they hit topics from airway management to doing a crike, to FAST, to helmet removal. So there's a wide range of videos that will pop up on your phone. And then there's a resources section, and this, I think, for our residents is very helpful. All the calculators and the formulas are there, and they, again, don't need a connection to the internet. The dermatome maps, guidelines for transfer, some very practical sort of things that you can use to treat the patients. And then finally, all the skill stations, or 10 of the skill stations with 29 different skills, are described, and all the step-by-step, and where appropriate, where there's images that are useful, those are also integrated into this. So all of that is available under the skills section part. Now, there are these complementary trauma courses. ATCN has been around for more than 15 years, and there's a dedicated course manual. It's run in parallel with ATLS, so same classes designed specifically for RNs. We've run multiple of these courses, and they are very effective, and something that you might want to consider. The classes are the same, and when you break out into the skills sessions, there's very specific RN-based skill stations. Then there's TEAM, which is designed for medical students at the senior level, and these are very general concepts of evaluation management. There's a very flexible lecture, case scenario, skill station type setup. So for anyone that's involved in medical student education, this can be broken up and integrated into your medical school curriculum. And then finally, the third complementary course I'm going to spend 5 or 6 slides on, because I think it's applicable to a lot of people that attend this course, and that is the Rural Trauma Team Development course. And as everybody knows, nearly 60% of the trauma deaths occur in rural areas, despite the fact that far less of those patients actually get injured in those rural areas. And rural patients, for a variety of reasons, are much more likely to die at the scene and of survivable injuries when you compare to urban areas. And these are the potential problems. There's problems with the discovery of the patient, the EMS mobilization, transport, transfers, and the in-hospital care because of the local resources. So RTTDC is focused on trying to improve these patient outcomes by teaching a team approach at the facility specifically, focusing in on rapid transfer. And they did this survey which showed that most of these rural trauma centers could at the very least get together a 3-person team. So everything's built around this 3-person trauma team. There's a trauma leader, which can be a physician extender, or a nurse, and then a combination of nurses, paramedics, even aides, orderlies, and clerks. It's a 1-day course. It's about 8.5 hours, and it happens at the facility where definitive treatment just can't occur. And again, the focus is on stabilization and transfer, and the instructors go to the facility so they can tailor the course to what's available there. It's all done as a team, and the target audience is physicians, nurses, advanced practitioner nurses, physician assistants, EMS, all the techs, RTs, blood bank techs, radiation, radiology techs, as well as the administrative clerks and all the aides that are present there. You can take up to 30 people into this course, and it's all designed to improve the care specifically at that facility. It's very inexpensive. It's about $50 a person, and this can all be done, as well as all of these courses, ATCN, TEAM, RTTDC, and ATLS. All of this information can be found on the facs.org website. Now, for the balanced resuscitation, I'm going to skip past all the rest of the stuff and go right back to that. And these are the 5 things that we're going to cover. The first 3 are expansions of what's in ATLS, and the last 2 were just brought up recently on that last break, so we just added some slides. So first of all, for the isotonic and hypertonic solutions, ATLS has really changed, and it's following our current practice. They really have emphasized the negative impact of giving too much crystalloid. They've in fact taken that word aggressive resuscitation out of the wording, and that standard 2-liter bolus that we used to give as part of the ATLS directorate is no longer there, and they have moved that down to 1 liter. They've taken hypertonic saline right out of the mix, which was a new change 4 years ago when the 8th edition came out, and that was all based on the ROCK trials done at 11 centers in US and Canada. They had 2 parallel trials, as you recall. One is for torso trauma, hemorrhagic shock patients. It was a randomized trial of hypertonic saline versus hypertonic saline dextran and normal saline, 250 cc bolus at 7.5%. This study was stopped at 853 patients because of futility, with no difference in 28-day survival, no difference in multisystem organ failure. In the parallel study looking at traumatic brain injury specifically, so GCS less than 8 after blunt trauma, this too was stopped after 1,282 patients for futility. Again, no difference in survival, no difference in neurologic function. So basically, they've dropped the amount of fluid following what we're in practice doing today down to 1 liter, and they've taken hypertonic saline right out of that mix. Now, what about plasma and platelets? Now, it's been talked about several times this morning. For patients in shock, they emphasize the early use of blood and blood products because we know now that these patients are not just bleeding blood onto the floor, they're bleeding a combination of blood or red cells, plasma, and platelets out onto that floor. Now, when you ask what is it that you should be transfusing your patients then, they do not specify in ATLS any specific ratio of plasma or platelets, because the reality is if you look at the data, neither the retrospective or prospective data is able to discriminate between patients that get 1:1:1 or 1:1:2. And if you look at the plasma data, you saw this study earlier this morning, you can see that when you look at the high ratio groups, these are the high ratio groups, 1:3 to 1:2 and greater than 1:2, the reality is very few patients in all of these studies were even getting 1:1. So there's a lot of studies, retrospective, but very few patients got a, quote, high 1:1 ratio, and most studies actually use 1:2 as the high plasma group. When you look at PROMPT, and Ali showed you this morning as well, they suggested the early plasma platelet use improves survival. But again, if you look closely at their data, they showed that less than 1:2 was better than, or was worse than greater than or equal to 1:1. But they were not able to discriminate between patients getting 1:2 and 1:1. And in fact, this is so much so that if you look at the PROPER trial, which is the ongoing multi-center randomized controlled trial, this is happening right now in North America, so in Toronto as well as 11 other centers here in the US. There was sufficient clinical equipoise so that the 2 study arms are a 1:1:1 ratio and a 1:1:2 ratio. Now, just for curiosity's sake, this was started in the fall of 2012. As of last Tuesday, everybody met in Dallas. 309 of 680 patients have been enrolled. So we're almost halfway there. The projected end of the study will be January of 2014. So hopefully very shortly after, we'll have some prospective randomized data on which we can base our practice. So if you look at all the plasma data that's currently available in the absence of PROPER, the best data is not randomized, but what we do currently have is fairly consistent, and more plasma, probably better than less plasma, and the target is probably a ratio greater than 1:2. Now, what about platelets? Just to decrease the confusion, there really are 2 platelet products that you can order, and your hospital will stock one or the other. The first is the older traditional single unit derived from whole blood type platelet. Those are the platelets that you order 6-pack, 8-pack, or 10-pack at a time. So the equivalent high ratio will be a 1:1 ratio. Then there's the apheresis platelets, where somebody goes in and they're a single directed platelet donor and they apherese off the platelets. These are large packs of platelets. You normally order a 1 unit or maybe 2 units at a time. The equivalent high ratio would be a 1:6 or 1:8. Now, the good thing is for almost all the studies, people just talk about a 1:1:1, and the assumption is that when you do a 1:1:1 for apheresis platelets, it's actually really a 1:6 or 1:8 ratio. Now, if you look at the platelet data, far less than the plasma data, but they all kind of look like this, much like the retrospective plasma data. As you, in this situation, decrease the amount of platelets patients get, the mortality increases at 12 hours, same holds true at 24 hours, and in hospital. And if you correct for all the differences, getting more platelets is equivalent to getting better survival. And in PROMPT, in the multi-center prospective observational study, the same early impact on survival was seen. So if you put plasma and platelets together, more plasma and more platelets, probably better than less, and your target should be at least a 1:1:2 ratio. So the reality is, I think at most of our centers, we're targeting a 1:1:1 ratio, knowing that in most cases, we're not going to hit that number. And so if you fall halfway between 1:1:1 and 1:1:2, you're probably good, because your target really should be greater than 1:1:2. Now, quickly, so that was the ATLS stuff. Now, on the break, 2 other issues were brought up. So Chris is somewhere in the crowd. He brought up one of the issues. And someone else brought up the issue of fibrinogen. So I just stuck these slides in there in the last 8 minutes or so. Fibrinogen, I would agree with the person that brought this up. It is really important, and it's probably underappreciated here in the US today. This is a study that came out just a couple months ago in JAX. We took a look at massive transfusion patients, 260 of them, who had admission fibrinogen levels done. You can see that if you stratify them into a normal level, so greater than 180, versus abnormal, between 100 and 180, or critical, less than 100, you can see that as you decrease the amount of fibrinogen that these patients have on board, you can see there's a stepwise increase in mortality that holds true at 24 hours, as well as for the increase for their entire hospital stay. And in fact, if their fibrinogen level is less than 100 when they come in, that is associated with a significant chance of dying. Now, CARM in London did a very similar study. This was prospective, 517 patients, and when they took a look at fibrinogen levels, as expected, the fibrinogen levels very closely tied into ISS, shock, and fluid requirements. But you can see that, again, the fibrinogen levels were a very strong independent predictor of mortality, again at 24 hours, but also at 28 days. And interestingly, the administration of cryoprecipitate as a treatment was associated with improved survival. So I think fibrinogen, as was mentioned, is an important building block and something that we really don't tend to think about a lot here in North America, but it's probably important. So when that patient rolls into your emergency department, you're going to send that coag panel off, knowing what their fibrinogen level is like, and then checking it again in the OR, and then checking it again in the ICU is probably important. And if that level is less than 100, it's probably worth treating. And then finally, this has been talked about again this morning as well, but Chris brought this very important point up, and that is the use of TEG, and I would really agree with what he said. So we know, as Ali showed us, that the available data has major flaws, and so there's probably no indication for the routine use in everybody of TXA. But I think that despite all the flaws that were brought up this morning, there probably is a subset of patients that will benefit. There probably is a subset of patients that we ought to be giving this to. Now, it's interesting, when Karen was in San Francisco at UCSF, he did the study. It's a classic, prospective, 208 patients, blood drawn at 10 minutes, and they correlated that to base deficit and shock. And one of the most important findings that he showed was that shock was very closely tied to hyperfibrinolysis. And when you look at this hyperfibrinolysis, this has a tremendous impact on outcomes. This is a prospective study where all patients at the highest trauma team activation level got TEGs done at admission, an hour, 2 hours, and 6 hours, and you can see that about 11% of patients ultimately became hyperfibrinolytic, and this happened early, between 2 to 60 minutes after admission. And for those patients that were hyperfibrinolytic, 62% of them had died of bleeding causes by 6 hours, and ultimately, 92% of these hyperfibrinolytic patients died, versus 10% of the non-hyperfibrinolytic cohort. And so maybe for TXA, it's the hyperfibrinolytic patients that may be the optimal target. And as Chris mentioned, this is the TEG or the ROTEM. Both are widely available clinician-operated point-of-care tests that can be done at the bedside with a very small amount of blood and very quickly. And it has been shown, predominantly in Europe, but by many centers, that you can use this practically in your trauma bay to detect hyperfibrinolysis. So it's a practical test that can be used in real life. And because of the picture that it spits out, you can see visually the clot breakdown as it's occurring in real time, or you can actually rely on a number. EPL is a typical sort of number that will be used. And maybe by using this cutoff or by using the visual demonstration of hyperfibrinolysis, this may be the ideal patient that benefits. So to summarize the TXA data, I think that it's true. Crash-2 matters. Clearly, they have major design flaws, no question. But there is some signal that's in there. And all of the flaws that we levy against these two studies all serve to dilute the magnitude of the effect. And if they weren't there, the results actually may have been better. And it's a pretty inexpensive drug, probably less than $100 at most centers for a gram. It's widely accessible and it's very easy to give. There are a lot of questions that we need to answer about who should get it, who shouldn't get it, how much should they get, when do they get it, how long do we give it for? There's a lot of questions. Most importantly, how does it work? We don't even know that. But nevertheless, there probably is a subset of patients that may benefit, and those that are hyperfibrinolytic, they may be the ones that we need to target, and it's clearly worth further study. And in one final slide, as far as the crystalloid, I think ATLS really does, and I think we all agree, suggests that we should minimize the amount of crystalloid resuscitation that we give to our patients. More plasma and more platelets earlier, probably better than less. The target at this time, best available data, is a 1:1 to 2 ratio, or in excess of a 1:1 to 2 ratio. Whether or not a 1:1 to 1 ratio is better than a 1:1 to 2 ratio, we simply don't know. And I think until the proper results come out next January, we really won't know the answer to that. And fibrinogen, I think, is something that is very underappreciated here in North America, and it's something that's probably worth measuring. And if that value comes in at under 100, we do have a very effective way of treating it with cryo, and we probably ought to be doing that. And I think that's it. So thanks very much.